Good afternoon, and welcome to Medication Reconciliation, Assessing and Evaluating Processes and Identifying High-Risk Situations. My name is Danara, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. I will now turn the call over to Ms. Toni Kettner. Ms. Kettner, you may begin.
Thank you, Danara. Welcome to the last of 4 Medication Reconciliation Safety Webinar Series. And again, this is Medication Reconciliation, Assessing and Evaluating Processes and Identifying High-Risk Situations. We have participants from all 3 states today that are a part of the Lake Superior Quality Improvement Network, and that would include folks from Wisconsin, Michigan, and Minnesota. So again, welcome to this last and final webinar series. So I'm required to read the continuing education disclosure, so bear with me while I do that, please. Because Medistar is providing continuing education credit for this presentation, we need to inform you of the following. No commercial support has been received for this learning activity. The speakers have reported no conflicts of interest, and there are no planner conflicts of interest. For continuing education credits or a certificate of attendance, you must attend the entire session and complete an online evaluation that you will receive. We encourage everyone to complete the evaluation to provide feedback on the session. And for your ease and convenience today, we've done a little process improvement here, and we have uploaded both the continuing education form and the PowerPoint slides to you. The PowerPoint slides were also emailed out to all participants early this morning, so hopefully everyone has received those and they're able to participate fully. And again, there will be a question and answer opportunity following the presentation. So again, we are using the MATCH toolkit from AHRQ as the basis for the webinar series. And again, that stands for Medications at Transitions and Clinical Handoffs Toolkit for Medication Reconciliation. And hopefully you've had an opportunity in previous webinars to be able to download that and take a look at that tool. So the objectives for today's presentation include describing why assessing, and in this case we're using the term assessing as auditing or checking for compliance, the new medication reconciliation process, which is critical for the success, to be able to compare strategies for assessing and evaluating the effectiveness of the redesign process. And then lastly, we're going to identify high-risk situations in which there may be barriers to addressing medication reconciliation and offer some opportunities to be able to work through those barriers. I would also like to just reiterate again that we are as part of the LSQIN using this as a process improvement tool. So you will have received an assessment, 9 questions, asking you various and sundry questions about your medication reconciliation process. So we ask that you have completed or will complete that to help us identify opportunities for further land events and to assess how well as a region we're doing with medication reconciliation. Following this last webinar, there will be a post-webinar assessment. Same 9 questions sent out. Again, we're asking that you complete those because in those 3 states we are using this as an intervention for the Centers for Medicare and Medicaid for our task. Following that, there will also be 2 more post-evaluation assessments going out so that we have a total of 6 months of data that we're hoping to be able to gather. If you have any questions about those post-webinar assessments, which are different from the continuing education evaluation that you'll be asked to do at the end of today's webinar, please let me know and I can answer any of those questions for you. So to begin, why evaluate and assess, or why audit? So we're looking during this process to ensure that the opportunity that we've identified for improvement has been adopted fully and that there's a complete adherence throughout the entire workplace, or whether that's a unit or a department, wherever it was that we might have implemented that, and that we can identify that there's actually been the change in practice that we wanted to see. It's also an opportunity to assess not only the quality of the intervention, but also quantity in terms of how widespread is it. And of course, we all know that data is very important. Data helps to drive decisions. It helps us to determine what steps we may need to take next. So it's a very important piece of the process improvement. And then it also ensures compliance. And again, many of us, through either regulatory, state and federal requirements, or perhaps it could even be joint commission, have to demonstrate that we're in compliance, not only with standards, regulatory standards, but also if we've identified a problem that has come up, they're going to come back and they're going to want to take a look at us being able to demonstrate that we've continued compliance. So they're going to want to look at some quality improvement statistics perhaps, and this is a way that we're able to demonstrate those and provide that information to them. And it's also a way that we can demonstrate to the staff that we're in compliance. So then to audits. So it's important that we had gotten some pre-implementation data, because we're going to compare that pre-implementation data to the post-implementation data that we're looking at and talking about at this point. So it's important to, after we implemented the process, to begin that auditing intervention, or begin to audit what it is that we've what processes we decided that we needed to put into place. We also want to make sure that we're doing it at every transition of care, and that could be at every clinic visit, it could be at every home health visit, it could be upon every admission or upon every discharge, every encounter with the patient. Because again, we want to ensure that this change is widespread and that everyone has adopted and accepted it. So this auditing process or assessing process really involves everyone who's involved in medication reconciliation. And again, depending upon the site that we're talking about, that could be the physicians, a nurse, medical assistant, pharmacists, technicians, students. So it could involve a lot of different people. And it's important when we're auditing that we're going to tailor the feedback that we're getting in this audit based on role and performance. So what I mean by that is, for example, we might not have the same conversation with a medical assistant about the audit results that they're finding as we would with a physician or a pharmacist. So again, to tailor that specifically to role and performance. And again, we're going to be looking not only at the whole, so compliance as a whole throughout the unit or the department or the organization, depending upon how widespread the process improvement was. But again, we're also looking at individual compliance. So this is just another a graphic that again displays the medication reconciliation process and supports the reason for process improvement and for auditing and for compliance. And I just wanted to add that slide to this particular section again, just to kind of give us a frame of reference for having those conversations with people. We've identified there was a gap in performance. We've put processes and things in place to try to close that gap, and this is what a good medication reconciliation process allows us to be able to do. Improve outcomes, improve reimbursement, avoid costs, be able to be in compliance with regulations and accreditation, but very much more important and really at the heart of it is the patient and patient safety. So when we're talking about auditing processes, there are opportunities to have manual or paper-based audits, and there are opportunities to do electronic forms of audits through the electronic health record. So there are pros and cons to each approach. There are issues related to the quantity of the number of records or charts that you're reviewing versus the quality that you're actually looking to see that the process that you implemented is actually being carried out and that it, again, has been incorporated into the culture. And there's a need to look at both. And again, quantity addresses the fact that the change has been adopted and it's being adhered to, whereas quality is looking more at demonstrating the impact on patient safety. And on page 50 of the Match Toolkit, there is a fairly good conversation that talks about the difference between electronic and manual assessments and audits. And what I have done with this slide is just kind of take that information from page 50 and kind of condense it into a little bit easier version to read. So if we're looking at electronic audits, those are certainly much easier to do. They're very efficient ways of tracking adherence. You can certainly, and through the electronic health record, do a significant more amount of records because it's easy to pull the information out of the electronic record. And you could conceivably sample, if you chose to do that and felt it was necessary, 100% of the patients or 100% of, looking at, for example, medication administration records. The manual retrospective, meaning it occurs at a time later, can be very time-consuming. You can, however, look at both quantity and quality auditing that way. And again, the sample size depends on the amount of time you have and resources. So if you're a small organization, it may be that it's the director of nursing or the assistant director of nursing or somebody doing infection control or quality that's actually taking on this extra responsibility, somebody who wears a lot of hats. And so that, again, may mean that you're going to have less time and you're going to be able to have less number of records actually reviewed. And again, when they're retrospective, it's really hard, I think personally, to affect a change because if you're noticing that there's an issue that occurred in the past, it's harder to go back to people and have conversations with them about that. Whereas if we're using the manual prospective, meaning it's occurring real time, it's much easier, as it indicates here, to be able to intervene on missed opportunities, and it's easier to provide feedback not only to the individual whom you noted missed the opportunity, but it's also a way for them to give you feedback and to try to figure out what barriers there are or were to preventing the intervention from occurring and act on those at the time. And I think staff would rather have, tell me now what's happening as opposed to like, okay, I did this a month ago and now you're coming, and so it's just, I think, more reliable, and it's an easier conversation to have. With a manual prospective audit, you can also look at quantity and quality assessments, and it's a little easier to target high-risk areas, and it allows another set of eyes on, for example, the medication record. So it's just somebody else coming through and taking another look relatively quickly following, for example, let's say the admission, and being able to catch things really quickly. So there's, I think, some value in doing prospective auditing. So metrics and assessment and audit tools. So it's important as we're thinking about collecting data that we had talked about doing it before the redesign, following the redesign, during implementation, and then until we know that process is hardwired into the culture. And then even after that, I think it's important to have periodic assessments so that you continue to be aware of any problems or any barriers that are occurring that might prevent this process from continuing for infinity, so to speak. It's also important when you're looking at data collection to consider how are you going to define compliance. So what will be the measures that you need to measure? What will be your numerator and what will be your denominator, and how are you going to define compliance? Is that 95% of whatever it is that you have implemented that you feel that that's appropriate, or is your goal 100%? And when it comes to medication-related issues, definitely, taking a look at the percentage that you feel will meet compliance is important, because it is such a high risk and patient safety issue. And I would be tempted to say that 100% would be almost where you would want to really shoot for. It's also important to consider how you're going to display your data and how you're going to communicate with your staff. So you can have simple run charts, you can have graphs, you can have tables. I've seen people get fancy and they have, like colorful kinds of different kinds of things that they can show to the staff and have those displayed that make it kind of more fun. Sometimes people even, take these kinds of things and make sort of a challenge out of it. Food is always a great, engager. And I've seen lots of departments and staff kind of take on things by themselves, and pretty soon you have departments competing with one another, and it's done in a friendly way, and can really help, again, boost getting that hardwired into the system. A word about audit tools. Again, they can be electronic, they could be paper-based. They should be really simple so that whomever is collecting the data finds it very easy to do. So check boxes are really good. Always having a place where they can keep some notes about things that they've observed. So if you need to go back and follow up, you can. But again, they don't have to be really complicated. And on pages 20 and 23 of the appendix in the Match Toolkit, there are just a couple examples of some audit tools that they have developed. There are outcomes versus process measures, and we're going to talk about those in a little bit more. And then how does this data correlate with other organizational metrics? So there are actually organizations out there, and I've named two, the National Quality Forum, AHRQ is another, the American Medical Association, that actually have predetermined or preset metrics that relate to a whole host of measures, not just medication reconciliation or medication related, that you can actually go to if you're kind of struggling with what maybe you might want to measure and what the numerator and denominator should look like that can actually help you. I will also encourage you, if you are having problems, to reach out to your regional task lead in each state that is working on medication safety, and that would be Heather in Minnesota and Gloria in Michigan and myself here in Wisconsin, and we'd be happy to help assist you in any way that we can to help you, kind of look at those kinds of measurement tools and audit tools, not just for this task, but for others as well. So again, outcome measures and process measures. So outcome measures are measures that look at the outcome of care and kind of look at assessing quality. So they're looking more specifically at individuals and populations that are attributed to healthcare. Whereas process measures look more at assessing adherence to a process or assessing a service that was provided. And it's defined here as an interaction between a healthcare practitioner and a patient, or a series of actions, changes, or functions that bring about a result. So, for example, an outcome measure for this particular purpose, if you were looking at medication reconciliation and you were concerned about the number of adverse drug events, the outcome measure might be the percentage of patients with an adverse drug event, whereas a process measure might be the number of individuals that received medication reconciliation on admission. So you can see one is more, the outcome measure is a little more specific and kind of more gets at patient safety kinds of processes than the process measure does. Looking at assessing and the audit results. So I had just indicated a bit earlier that it's really important to communicate the results of the audits to the staff. And again, that's all of the staff who are participating or involved in the process, because it reinforces the need for the process and reinforces the need that the gap that you identified needed to be corrected and is important in patient safety. It also is important to communicate those results to staff, and you can do that in a whole host of ways. So again, simple run charts, simple graphs, very simple kinds of pictorial sorts of things posted on a board, talked about and discussed at team meetings, at huddles if you have those in the morning, just to keep people aware of where it is that you're going, where it is that you are right now and what the goal is, and again to invite any kind of feedback and communication about any frustrations that people are having, any barriers that they see, and again it's always important if you can address those in a timely fashion and get that feedback in timely fashion. It will also help support the process change that you're making, and again allow staff to have that feedback, which again makes them feel more of an ownership for that. It also allows for transparency. It improves decision making, and again, data drives decisions. And I'll just give an example related to that from my past. It doesn't have to do with medication reconciliation, but it will just give you an example. When I was the director of home care, my staff were talking a lot anecdotally in meetings that we had about the number of calls that they were getting on the weekend and how frustrating that was. And so I was concerned and wanted to take a look at that, because the question that I had, or one of the first questions that I had was, is there information that we're not giving our patients in terms of some kind of education that is prompting there to be all of these, calls being made? But again, I was just making an assumption. So for 3 months, I actually had them track on the weekends when they got a call, what time it was, how long it lasted, and what it was about. It was very simple, and then they could make any notes. So we looked at that for 3 months, and when we came back together as a staff after we had collected all the data, and they were collecting the data, so they were very much involved in the process. What came to fruition was there weren't that many calls on the weekends, and the ones that there were had to do with things like wound vacs, like other wound-related kinds of things, and questions about, just kind of how to handle certain other. They were reporting things that we actually were needing them to report and wanted them to report. So we came back together as a group and looked at that, and so again, it's data. So we didn't make it up. I didn't make it up. We all owned it, and we were able then to make some changes in what education we were able to give to wound care staff that helped decrease those calls a little bit more. But the overall result is that they weren't really getting called out a lot. It was the perception And again, their perception was their reality, so I wanted to, acknowledge that. But again, it just helped us to be able to move forward from that. So data is very important. So again, this is taken out of Chapter 6, and it's just an example. I have used something similar to it as a way of presenting data, kind of in a bigger picture. So this is looking at these three particular measures: medication reconciliation on admission, on transfer, and then the medication list at discharge. So it's just an example of how they defined what the numerator and what the denominator was going to be, because that's important for anyone who's collecting the data. And then the goal, and again, you would want to insert your current compliance, and they've used greater than 90%. I typically have use something like greater than 95% where it came to medication related and items, and again, you may want to look at even 100% because it's so important. But again, you have to decide that individually. And then they allowed an opportunity for an action plan. So if there's a gap in the period of time that we're looking at this, what are we going to do, or what kinds of interventions are we going to employ to bring that up to where it is that we need to be. So this is just an example that you might find useful. Okay, so increasing and sustaining compliance. So lots of folks and lots of organizations are very good at putting together a performance improvement plan and rolling it out, but the rubber meets the road when it comes to sustaining compliance, and sometimes that can be the most difficult thing to maintain and to do in a process improvement project. So it's important to continue to identify and address barriers to adherence. And those may involve more global issues. They may be more related to a particular staff person. And of course, it needs to be recognized and addressed accordingly, but always in a way that puts the onus back on the process, not the person. It may be something that if you're seeing a barrier and there just seems to be non-compliance that's sustained, you might want to perform a root cause analysis and look at what is really going on, what's really at the heart of the matter. Another tool that's really useful and is very similar to a root cause but isn't quite as complicated is the 5 whys. So you ask yourself or ask your staff why 5 times, and usually once you get to the 5th why, you're really getting to the heart of what it is that's preventing that buy-in or that problem with the culture change or the barrier, whether it's a lack of knowledge or training or whatever it might be. Also in this process, it's important to identify strengths and opportunities for improvement. So there might be something that's really going very well, and your staff need to know that, and you need to be able to acknowledge that. If we continually are going to people and kind of like, well, this isn't working and we're not getting here, and with kind of a frustrated, people start to kind of take that personally, and so it's important to let them know when it is and what it is that they're doing really well and celebrate that strength, and then to bring in their ideas and opportunities for how you might want to get past whatever this barrier is. Conducting focus groups could be a little bit time-consuming. Sometimes it's just as easy as having conversations with individual people and being able to get at what it is that's going on. Sometimes, I think sometimes in groups, sometimes people won't speak out as much as they will if they're actually being asked one-on-one. And it's a nice reason, or gives a nice chance to just kind of have a conversation also with individuals. Leader rounding can sometimes also work. I have seen that work where you're doing rounding, and again, you're really facilitating getting information and conversation with the staff who are doing the frontline work. Again, I think people have to be able to feel comfortable with that, and so again, depending upon the culture, that might work better in some organizations than in others. And also another opportunity that you might have is if you've got a department that's doing really well, or staff members who are doing really well with the change and are really have embraced it, to look at partnering those departments or staff with maybe those who are struggling. And again, I think this has to be done in a really thoughtful way so that the people who are getting the partners understand why it is, and they're willing and able to accept that. This slide is also in the match toolkit, and I just wanted to add it for just a kind of the sake of conversation. So it's the National Coordinating Council for Medication Error Reporting and Prevention. And if you're looking at errors in your facility, if you have like an online risk management tool, this could possibly be built into the system. It also might be built in if you're using a paper system. Some I have seen have it built in where you're actually kind of grading the error on the level of severity that occurred. So A would be the least severe, that there was no error, but it had the capacity to cause an error, all the way to H, where the error could have resulted in death. And it gives you an example for each one what those might look like. So, A was they don't have an example in this particular case. I is that a beta blocker wasn't reordered post-operatively, which could have caused significant harm to the patient. So just be aware that tools like that are out there if you wanted to, take a look at how that might be integrated into your organization. Okay, so Chapter 7 of the Match Toolkit discusses high-risk situations. And those high-risk situations have to do with health literacy, patients with cognitive impairments, and then external transfers. And we've already indicated, I think, in one of the earlier webinars that transfers are one of the most common periods of time where there can be issues with medication reconciliation and errors can occur. So they're very important barriers or challenges in medication reconciliation. So let's talk about health literacy first. So health literacy is defined as the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. So that's, I think when I read that, that really kind of took me aback for a minute, because so not only do I have to have the capacity to obtain it, so I have to know where to get it, how to get it, I have to be able to process it, and then I have to understand it. And when we think about the amount of information which we are giving our patients, it's a wonder that any of us can do all three of those things and do them well. And then if you add in that I now only have a 3rd or 5th grade level of education, that even makes it, I think, more imperative that we really take this seriously. A 2006 study by the U.S. Department of Education found that 36% of adults, so that's 1/3 of adults, really have only a basic or below basic understanding. And I know I have said earlier that I think we really need to take a look at looking at things at a 3rd grade level. When I was at the Health Literacy Summit earlier this year, that's what they were indicating. This is suggesting that 90 million Americans can understand discharge instructions written only at a 5th grade level. And whether it's 3rd or 5th grade, I think that we really, as organizations, need to take a really good look at how we're communicating the information that we want people to understand, and at what level we're doing that. And I think we still have a long way to go and a lot of opportunity to be able to make that better for our patients. So poor health literacy has been it's documented that it leads to an increased risk of medication errors. It leads to poor adherence with medical interventions. It increases healthcare costs because if people don't understand how to do things and then they get into trouble, they're likely going to have an emergency visit or an inpatient visit related to that. And they also, it leads to inadequate knowledge of their chronic condition. And if they don't have the knowledge of how to take care of themselves, then we really can't expect them to be adherent or to be anything else. So I think it's safe to assume that everyone, and I would even say, though I'm a nurse and I've been in healthcare for a long time, even myself would have some difficulty understanding health-related information. And just consider this, I'm sure some of you have had surgery just like I have, and you come home with these reams of paper, and maybe you're on some medication, and you're expected to read all this and take it in, and maybe you don't have anyone else in your home, who can help you or support you. So again, I think health literacy is something that we don't pay enough attention to. So how to optimize communication. There's a lot of literature out there and resources about teachback and how it can help confirm an understanding. And it's something that can be used with all patients regardless of their socioeconomic status or any other thing. And it can help the clinical staff identify individual communication strategies for each patient. And it should be written at least a 5th grade level, maybe even less, and pictures can be very helpful. So just to kind of reiterate this, there's our estimates that 40 to 80% of the information that we get, we forget pretty immediately. So that's huge, 40 to 80% of the information. I might have a conversation with a patient and then they go out the door and that's like 40 to 80% of it is just gone. So teachback gives us the opportunity to be able to have conversations and really get at the heart of what the patient understands. And it's not just asking them to necessarily, we don't want them to necessarily repeat back. We really want to get at what it is that they understand. So again, there's lots of literature and lots of tools out there, videos that can help you do teach back well, that you could use with your staff. So it would be things like saying, so tell me what you're going to do with this particular medication when you get home. So it's kind of open-ended questions that allow them to really kind of have an opportunity to give you an idea of what it is that they've understood, so that then you can help them if there continues to be a barrier and or that they have grasped the idea and you're fairly comfortable that they're going to be able to be successful. The next high-risk situation for medication reconciliation has to do with cognitively impaired patients. And I know we have all been in situations where we've had to work with an individual, a patient who had a cognitive impairment and maybe didn't have any family members or anyone to advocate for them, and it makes it very, very difficult and is very frustrating, not only for us as healthcare providers, but also for the patient. And it certainly makes any kind of education about medications or any other health-related information very, very difficult. So there are multiple screenings for cognitive impairment. One is the mini Cobb assessment, which has been shown to be a good predictor. I think that occupational therapists can be really awesome at helping you determine a patient's cognitive impairment. They have some good strategies and good tools that they can use, and I have used them in both hospital setting, home care, and in nursing homes to help when we had a patient that we we're concerned might be cognitively impaired. And also, just as a reminder, some patients are very, very good at covering up their cognitive impairment until they're asked to do some of these assessments, and then that's where, you can really get a good understanding. I've also been in a situation, and this may have been something that isn't out there in large numbers, but when I was in the nursing home, we had access to a geriatric nurse practitioner who worked in a clinic where they did geriatric assessments, and it was really looking at helping people with cognitive issues really have good quality of life, and helping them to identify strategies that could help them continue to be independent. But she also was able to do some really good assessments that really helped us determine how much the patient was able to rationalize, how much they understood, how much they were able to process. So again, depending upon your setting, there might be multiple people, not only in the setting, but also within your community that may be able to help you do a deeper dive into an assessment for cognitive functioning. So referring people for further assessment is good. Being proactive, being able to adopt some kind of universal approach regarding communication with patients, communicating the concern to the primary care practitioner if you're not that particular person, encouraging patients to take their medication list with them and even their medications. And I know it's, when people come in with all their meds and, bag, we kind of go, oh my goodness, but it really does, in the end, I think, help so that we're really understanding what they're taking, and we can, again, it helps us to understand if they're having some cognitive issues or they don't have enough education to be able to take the medications appropriately. And then also, don't forget the community pharmacy and pharmacists are very important, and they can also help you sort of piece together information. And I think maybe they're not, used as much as we could potentially use them. Other kinds of opportunities that there might be, referral to home care. Again, there's the homebound requirement, but more than not, there's a lot of people who do meet that, and they can go in and help assess the medications. They can help set medications up. Many pharmacies have the opportunities for the drug dispensing systems, which also can help people be more compliant. Again, referrals to ADRC, aging groups in your states, depending upon what those might be. So lots of resources out there that can help people with cognitive impairment. And the third high-risk area has to do with external transfers. So that's a hospital, or that could be a transfer from the hospital to the nursing home, from the nursing home to home care to the hospital. And those are really prime opportunities for there to be challenges in medication reconciliation. So it's important, to be, when you're involved in a transfer, to be sure that if you're the facility that is sending the person in, to have some really good documentation that you're sending along about what medications that you're aware of that the person is currently taking, to provide a list or some kind of documentation to the receiving facility. It's always good practice to call and have a conversation, kind of doing the SBAR sort of process. So any information that we can share with each other, I think, is really beneficial. Some of us are fortunate enough that we're in an area where we can and do share medical record information. Some of us don't have access to an electronic health record for each other. So again, really making sure that we're providing good documentation and good communication, so that the next so the hospital, if it's a nursing home to hospital discharge, again, has a much easier time being able to reconcile the medications on their end. So making sure that we're taking a look at current medications, if there are medications that have been discontinued, just so we continue to have that one source of truth that we're all using. I think establishing a universal process of who is responsible for what. And I know there are lots of initiatives going on in communities all over where there are partnerships between the hospitals, the nursing homes, the home health agencies, and pharmacies, and they're all looking at how they can systematically improve the process of medication reconciliation, from one institution or organization to the other. And I think those are really phenomenal that they're doing that and really taking a look at how they can all improve, how they can all share information, because really we all need the same thing and we all want the same thing. And so, why not share and why not work together to try to achieve better outcomes for the patient, because it really behooves all of us. And then continue to identify gaps in the processes is also really important. So, to be able to have opportunities where, again, you have feedback from each other. I used to really appreciate it when I transferred somebody from home care into the hospital and there was a glitch or a gap in something, that they were able to call me back and we could have a conversation about that. You just have to be open to that, but again, it's really not about the organization, it's really more about the patient. And so I think it's very important to have those communication lines open so that you can not only give but receive information. So in conclusion, I think this whole series on medication reconciliation really in the end has, to summarize, we would like one source of truth. We really want to provide care like you would want your family member to experience, and I think that we all do a really superb job of that. A sound medication reconciliation process has to involve all disciplines. It has to integrate into the workflow. It has to have leadership support. There has to be really good communication and buy-in. It has to become part of the culture. It's important to continue to implement interventions as process gaps or barriers are identified, and it really is a continuous feedback mechanism and needs to continue to be supported once it's rolled out, and then, as I indicated earlier, kind of through infinity or until something changes and you need to go back and again change that process. So there'll be an opportunity now for the operator, for the participants, to ask any questions or make any comments. And so I'll turn that over to the operator.
Thank you so much. We will now begin the question and answer session. If you have a question, please press star, then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. There will be a slight delay before the first question is announced. If you're using a speakerphone, you may need to pick up the handset first. Once again, if you have a question, please press star, then 1 on your touch-tone phone. Waiting on standby for questions. And I'm not showing any questions at this time.
All right, we'll give it maybe just a little bit more, and then we can conclude today's webinar. Just want to be sure that there aren't any questions about any of the assessments or the online evaluation or PowerPoints or anything related to today's event.
Once again, if you have a question, please press star, then 1 on your touch-tone phone. And our first question comes from Ms. Kathy White. Please go ahead. Your line is open.
I hate to tell you this, but I was late in the beginning of the webinar, and I was wondering if there's any opportunity that I could receive the PowerPoint and the wording on this webinar.
Okay, sure, Kathy. The PowerPoint would have been sent out to you early this morning from the secretary here at Metastar, but they're also linked in today's PowerPoint slides, both the evaluation and the PowerPoint slides. So are you still signed in that you might be able to see that in the chat box and retrieve that?
I am still signed in, so I've got the chat box. I mean, I didn't get any of the, I don't believe received the, but I haven't gotten through all my emails, so what can I click to get the multimedia viewer? No. Chat?
Yes, if you're in chat, you should see a link to the PowerPoint slides. And we'd be happy to make it easier for you. We can also re-email those to you. If
Thank
that would
you.
be helpful. Yeah,
How
absolutely.
to do that?
Okay.
Thank you.
You're welcome. Okay, there's a question in chat. Can you give me an example of a process or outcome measure that a local organization has used? Okay, I am not aware of, I haven't specifically had contact with somebody who's necessarily working on the medication reconciliation, so I'm, not able to speak from a participant perspective. But a process measure might be the one that I indicated, for example, the number of individuals receiving medication reconciliation on admission. So speaking to that, maybe you had identified that there was a gap in your performance about having medication reconciliation done consistently on admission, or at the beginning of a clinic visit, or at a home care visit, or on admission. And so that would be one example of a process measure. And perhaps you had identified that there was an issue with an adverse drug event related to your medication reconciliation process that you had wanted to focus on. So that might be something like the percent of patients receiving medication reconciliation that had an adverse drug event related to, and maybe it was with a specific medication, so let's say with anticoagulants. That you had observed that there was an issue. So those are just two examples, one of a process, one of an outcome measure. And again, if you needed additional help with those, the 3 task leads in each state would be happy to help you identify what those might look like, specific to whatever it is that you're working on.
Once again, if you have a question, please press star, then 1 on your touch-tone phone. Waiting on standby for additional audio questions. And I'm not showing any further audio questions at this time.
Okay, well again, I'd like to thank everyone for participating in today's webinar. And again, if you have any questions specifically, if you would email me those, and then I can in turn forward those to the task lead in Michigan and in Minnesota if that's specific to them. So again, thank you very much.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for